Every year, millions of Americans get a colonoscopy, get told everything looks fine, and walk away thinking they're in the clear. And then, some of them develop colon cancer anyways. Not because the colonoscopy failed, but because of what nobody told them about what the results actually mean and what happens next. Hi, my name is Dr. Matthew Glover, and I'm a clinical gastroenterologist working in Las Vegas, Nevada. I have personally performed over 10,000 colonoscopies, and in this video, I'm going to tell you the things that get left out of that 5-minute conversation you have with your doctor after the procedure. The things that could genuinely save your life. Because colon cancer is the second leading cause of cancer death in the United States, and a large percentage of those deaths are preventable. Not just detectable, preventable. And yet people are walking out of their colonoscopy appointment without the information they need to actually prevent it. So if you've ever had a colonoscopy or you're about to, this video is for you. Stay with me because by the end of this, you're going to understand your results in a completely different way. Before we get into it, quick favor. I see comments all the time from people who have watched a few of my videos and didn't realize they weren't actually subscribed. So would you mind just double checking that you are? It's free, it takes 2 seconds, and it genuinely helps this channel reach more people who need this information. And if you already are subscribed, thank you. You're not just watching, you're part of something. And I appreciate you being here. Okay, let's get into it. So let's start with the most common misconception that I see, and I see this constantly in my practice. A patient comes in for a follow-up. I ask how their colonoscopy went, and they say, "Oh, it was fine. Everything was clean. No polyps." And they say this with a sense of relief, like they've been given a free pass. Now, here's what I want you to understand. A clean colonoscopy is great news, but it's not a guarantee. It's not a shield. It is simply a snapshot of one moment in time in a colon that is continuously changing. Think about it this way. Imagine you take a photograph of your lawn in early spring. It looks perfect, not a weed in sight. But that doesn't mean weeds won't grow. It means there are no weeds right now. And if you put that photograph in a drawer and never look at your lawn again, you're going to have a problem. And that's exactly what a colonoscopy is. A photograph, a snapshot in time. An incredibly useful, potentially life-saving photograph, but a photograph, not a guarantee. The colon does not stop changing because your last scope was normal. And this is where the conversation about surveillance intervals becomes critically important, because not everyone needs to come back at the same time. Now, when most people hear colonoscopy, they hear every 10 years. And if everything is truly normal, no polyps, good prep, complete exam, 10 years is a reasonable interval. But that guideline applies to a very specific group of people. If you have polyps, and the majority of people over 50 do have at least one, your interval changes. And here's where it gets nuanced, because not all polyps are created equal. There are 2 main types I want you to know about. The first is a hyperplastic polyp. These are incredibly common, especially in the lower colon, and in most cases, they carry a very low malignant potential. And if this is all you have, your risk profile is low, and your follow-up interval may still be extended. On the other hand, the second type of polyp is an adenoma, and this is where things get more serious. Adenomas are considered precancerous lesions. They are the polyps that, if left alone, have the potential to progress to colon cancer over time. Not always, not quickly, but the risk is real, it's measurable, and it is exactly why we screen. Now, within adenomas, there are further distinctions: size, number, and whether something called high-grade dysplasia is present. Each of these factors changes your recommended follow-up interval. One small adenoma, different recommendation than 3 adenomas. 3 adenomas is different than 1 large with advanced features. And here's the problem. Most patients leave their colonoscopy not knowing which type of polyp they had. They know polyps were removed, they sometimes know how many, but they don't know the pathology. They don't know what the biopsy showed. The pathology report is the most important document that comes out of your colonoscopy. And a lot of patients never see it, never ask for it, and never understand it. And look, this process takes time. On average, it takes 10 to 15 years for a normal colon to travel the full pathway from a small polyp to cancer. That window is enormous. That is exactly why a colonoscopy is so powerful. We can find the polyp and remove it before it ever gets the chance to morph into something more dangerous. But only if the right polyps are found, correctly identified, and followed up at the right interval. Now, I want to share a study that radically changed how I think about colonoscopy quality, and it's one I think every patient deserves to know about. In 2014, a landmark study was published in the New England Journal of Medicine, one of the most prestigious medical journals in the world. Corley and colleagues looked at over 314,000 colonoscopies performed by 136 gastroenterologists in a large healthcare system. What they found was remarkable. Every gastroenterologist had something called an adenoma detection rate, the percentage of their colonoscopies where they find at least one adenoma. And what this study showed is that your doctor's detection rate directly predicts your risk of developing colon cancer after that procedure. In fact, they found each 1% increase in a physician's adenoma detection rate corresponded to a 3% lower risk of cancer in their patients and a 5% lower risk of fatal cancer. 5% for every one single percentage difference between doctors. And when they looked at the extremes, patients whose doctors had the highest detection rates, these had roughly half the risk of developing cancer in the years after their colonoscopy compared to patients whose doctors had the lowest rates. Half the risk, same procedure, different outcome, based almost entirely on the skill and thoroughness of the physician doing it. What this tells us is that not all colonoscopies are equal. The tool matters, but the person using the tool matters just as much. And this is something patients almost never think to ask about. Now, I'm not telling you this to scare you. I'm telling you this because you have a right to ask your gastroenterologist what their adenoma detection rate is. It's a real, measurable quality metric. High volume centers track it, and the answer matters. Now, I want to talk about something that sounds unglamorous, but is absolutely critical: the bowel prep. I know, nobody wants to talk about prep. It's uncomfortable, it's inconvenient, and patients dread it more than the actual procedure. But here's what I need you to understand. A poor prep can make your colonoscopy essentially useless. And there is published research that makes this very concrete. A study in gastrointestinal endoscopy followed patients who came back for a repeat colonoscopy after a suboptimal prep the first time around. What they found is that 42% of adenomas found on the second exam had been completely missed the first time. 42%. And for advanced adenomas, the more dangerous, larger kind, the miss rate was still 27%. Let me say that again. If your prep was suboptimal, there's a real chance up to 4 in 10 precancerous polyps were simply not seen, and you walked out of that appointment believing your exam was normal. Now, a good gastroenterologist will document your prep quality in your report. Look for something called the Boston Bowel Preparation Scale. It scores each segment of the colon from 0 to 3. You want a total score of 6 or higher. If it says poor or inadequate prep, the recommendation should be to repeat the colonoscopy, not wait 10 years. If your doctor never mentioned prep quality to you, ask for your procedure report. Look for that documentation. This number is not a formality. It is a direct measure of how much your colon was actually seen. Let me tell you about a pattern I see in practice that genuinely concerns me. A patient comes in at age 55 or 56 for their first colonoscopy. Everything seems fine. But when I go back through their history, I find out that their father had colon cancer at 62, or their sister had advanced adenomas at 55. And that changes everything. The clinical guidelines from the U.S. Multi-Society Task Force on Colorectal Cancer are very clear on this. And these are evidence-based recommendations that gastroenterologists across the country follow. If a first-degree relative, that means a parent, sibling, or child, was diagnosed with colon cancer before age 60, you should start screening at age 40, or 10 years before their diagnosis, whichever comes first. That's not a maybe, that's a clinical guideline. And it's not just colon cancer. There are things such as colon cancer equivalents. For example, if a first-degree relative had a significant adenoma, a large precancerous polyp, diagnosed before the age of 60, the same earlier start applies. These are considered to be colon cancer family history equivalents. That means there are many people sitting in my waiting room every day who are already behind on their screening simply because no one did a thorough family history. So I want you to do something specific right now. Write down your family history of colon cancer and polyps, first-degree relatives, age at diagnosis. That information belongs in your chart, and it should be shaping your screening strategy. If you're not sure whether your family history changes your timeline, that is a conversation worth having with your gastroenterologist specifically, not just your primary care doctor. Now, I want to spend a few minutes on prevention because this is the conversation that almost never happens at the end of a colonoscopy appointment. Your doctor removes the polyps, tells you when to come back, and you're done. What almost never gets discussed is what you can do between now and your next scope to actually change your risk. And there are things that truly work. Dietary fiber has a well-studied protective role, not in a vague general health kind of way. There is specific evidence around fiber intake and colorectal cancer risk. Whole grains, vegetables, legumes, these are not just good for you platitudes, they're mechanistically relevant. Physical activity also matters. This one surprises many people. Regular moderate exercise has been associated with a meaningful reduction in colorectal cancer risk across multiple large studies. The mechanism involves things like gut transit time, insulin sensitivity, and inflammatory pathways. Movement is not optional when it comes to your colon and microbiome health. Processed red meat is on the other side of the equation. The evidence here is pretty consistent. Regular consumption of processed meat is associated with increased colorectal cancer risk. In fact, the World Health Organization, the WHO, classifies processed meat as a group 1 carcinogen for colorectal cancer. That is in the same category as tobacco smoke. I'm not telling you never to eat these things. I'm telling you the data is real, however, and most patients have never been told. And here's what I see patients doing that doesn't work. They take supplements they read about online, they follow extreme detox protocols, they drink specific juices. None of this has meaningful evidence behind it for colon cancer prevention, and it creates a false sense of security that I think is dangerous. The interventions that work are not exciting, they don't go viral, but they are real. And I want to end on something important, and I want you to hear this clearly. Colonoscopies are screening tools. They are for people with no symptoms. The moment you have symptoms, and I'm going to tell you exactly what I mean, the calculus changes completely. A change in bowel habits that persists for more than a few weeks, narrowing of the stool, change in stool caliber, rectal bleeding, blood in the stool, unexplained weight loss, abdominal pain that doesn't resolve, fatigue and low iron with no explanation. These are not things you watch and wait on. These are not things you attribute to hemorrhoids without being evaluated by a physician. These are not things you manage with over-the-counter treatments and hope will go away. I see patients in my practice who waited 6, 8, even 12 months with symptoms because either they were embarrassed or assumed it wasn't serious, or they were told it was probably just hemorrhoids. And some of these patients had cancer that was completely operable when the symptoms started, that had advanced by the time we scoped them. If you have persistent GI symptoms, you need a colonoscopy. Not in 6 months, not at your convenience, now. So let me bring this all together. A colonoscopy is one of the most powerful cancer prevention tools that we have, but it only works if you understand what your results actually mean. If you know your correct follow-up interval, if your prep was adequate, if your family history is factored in, and if you're doing the things between procedures that actually change your risk. That 5-minute post-procedure conversation doesn't cover all of this, and now you know why that matters. So here's what I want you to do. Pull up your last colonoscopy report if you have one. Look at the prep quality. Look at the pathology results. Look at the follow-up recommendation. And if anything is unclear, if you don't have that report, if you don't know what your polyp type was, call your gastroenterologist office and ask. You have every right to know that information. It's your procedure, your body. If this video helped you understand something you didn't know before, leave a comment below. Tell me, have you heard of any of this before? I truly want to know. And if you want more content like this, evidence-based, clinical, the things your doctor doesn't always have time to tell you, subscribe to the channel because that's exactly what we do here. Thank you so much for watching. I'll see you in the next one.